Hello. Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am. You are audible, ma'am. Seven is sharing the screen, ma'am. In the meanwhile.
Sure, we can start now.
Yeah, thank you, Seven. Ma'am, with your permission, shall I start?
Yeah, sure.
Yeah, thank you, ma'am. Good afternoon, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to comment your questions in the comment box so that at the end of the webinar, we will have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Reeta Nath, who is a consultant ops and gynecologist at HM Hospital and Diagnostic Center, Assam. And with this, we welcome you for today's webinar, ma'am. And coming to the today's webinar, as we know that women with history of GDM are at an increased risk of adverse maternal and perinatal outcome, and also at increased risk of future diabetes, predominantly type 2, including their children, and therefore there are two generations are at risk. So now, without wasting much time, let me turn over the time to Dr. Reeta Nath to talk on gestational diabetes. Over to you, ma'am.
Okay. Thank you so much for inviting me to speak over this platform. Thank you very much. Today, I'm going to speak over a very common disease of pregnancy. This is the gestational diabetes mellitus, which is increasing day by day. We can proceed. Please, slide, please. Next, please. Introduction. So the previous one, please. Okay. One of the most common medical complication of pregnancy, GDM, and it affects mother, fetus, and outcome of pregnancy. So early detection is very much necessary. So it is defined as the impaired glucose intolerance with onset or first recognition during pregnancy. And undiagnosed and inadequately treated GDM can lead to significant maternal and fetal complications in future. Next, please. The prevalence rate of GDM in India is around 6.2 million live births that are affected by hypoglycemia in pregnancy, and out of which is 5.9 million are due to GDM. And because of the lifestyle and late marriage, it is much more common in the urban areas, which is lower in rural areas. There was a study in Tamil Nadu which shows that urban areas affected percentage is around 17.8%, where it is rural areas, it is only 9.9%. Next slide, please. Now, FOXI guidelines 2021. GDM is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity with onset or first recognition during pregnancy. It includes women with undiagnosed pre-existing diabetes as well as women with first onset hyperglycemia during pregnancy. So earlier, it was categorized into less severe GDM, which was referred to as the impaired glucose tolerance, and more severe GDM. But now the whole higher end of the glucose spectrum is more simply referred to as the GDM. FIGO recommends the term hyperglycemia in pregnancy, whether the diabetes is before pregnancy, during pregnancy, or because of the pregnancy. Next slide, please. So what are the short-term and long-term complications because of GDM affected mother? So it affects both the mother and the fetus in utero as well as the after birth also. So the mother complications are during pregnancy. It can there is higher chances of preeclampsia during labor. There are in case risks of induction of labors, operative delivery, cesarean section, and labor complications, and postpartum and beyond. There is a higher risk of developing the GDM in future pregnancy as well as developing type 2 diabetes in later ages. In case of offspring, the congenital anomalies can happen in GDM mother like CNS cardiac abnormality, large for dead babies, macrosomia, increased fetal mass. And neonatal complications include prematurity, perinatal ectasia, respiratory distress, metabolic complications, polycythemia, low iron store, hyperbilirubinemia, cardiomyopathy, etc. And long-term complications in newborn, later in childhood or later in adult life, increase the risk of obesity, type 1 and type 2 diabetes both, and other metabolic syndrome. Next slide, please. Now, consequences of GTM is not diagnosed and not treated. Maternal complications, there is always increase in the risk of preeclampsia, infection, laceration, cesarean delivery, long-term sequelae, like uncontrolled diabetes in future. In fetal, growth abnormalities, as already told you, and polyhydramnios, fetal demise, etc. And neonatal birth injuries, hypoglycaemia, seizure, polycythemia, electrolyte imbalance, other electrolyte imbalance like hypocalcemia, hypomagnesemia, hyperbilirubinemia, and respiratory distress, etc. Now, identification of GTM, screening and testing. For GTM, the most diagnostic test of choice is oral glucose tolerance test. This test is usually administered when the patient first visits at the antenatal checkup and between 24 and 28 weeks of gestation. A plasma blood glucose sample is obtained following an overnight fast, at least minimum of 8 hours, and then a 75 gram of glucose or 100 gram glucose load is given, and further plasma blood sample is collected after 1, 2, and 3 hours. It is diagnosed depending on the criteria used. If 1, 2, or more glucose levels are equal or exceeded, then she is categorized in different categories. Now, screening and testing, continuation of that. The SCOG and NICE recommended women who have had GTM in a previous pregnancy should be offered diagnostic testing as early as possible. SCOG also recommends early testing in obese women and women with impaired glucose metabolism as early as possible to identify undiagnosed type 2 diabetes mellitus. The Australasian Diabetes and Pregnancy Society recommends risk factor assessment in early pregnancy. Risk factors are ranked by severity. Either 1 high risk factors or 2 moderate risk factors are needed before an OGTT is offered. Now, proposed guidelines for screening for GTM in India. Universal screening at the first booking when the patient comes to our antenatal checkup, fasting blood glucose to be done. If fasting blood glucose is less than 92 milligram per day, it is diagnosed as non-GTM. Then single step OGTT is further done using 75 gram of glucose in the fasting set at 24 to 28 weeks of gestation. If fasting is 92 to 125 milligram, then she is diagnosed with GTM. If fasting is more than 126 milligram per DL and glycosylated hemoglobin more than 6.5%, then she is diagnosed with overt diabetes. So in case of those tested at 24 to 28 weeks of gestation with 75 gram glucose, we use IAD-P as the criteria for GTM. That is fasting 92 milligram per DL, 1 hour 180 milligram per DL, and 2 hour 152 milligram per DL. These are the cutoff values. If there is any abnormality of this, then it is she is categorized as GTM, having GTM, and if all values are normal, then she is diagnosed with free from GTM. In high risk cases, repeat GTT again tested done at 32 weeks of gestation. Now, current and previous criteria recommended to diagnose GTM are 75 when it is 75 gram of glucose, oral glucose tolerance test is done. So according to different societies, there are some cutoff values, and we can skip this slide. Now, protocol for investigation. Testing for GTM is recommended twice during antenatal checkup. First, already say when the patient first comes to our antenatal clinic that the first time, and if she is diagnosed with non-diabetic, then again we'll repeat the test at 24 to 28 weeks of gestation, because during this period the pregnant women mostly develop the hyperglycemia. And the test to be conducted for all pregnant women, even if she comes late in the pregnancy for ANC at the time of first contact. If she present when 28 weeks of gestation, only one test to be done at the first point of contact. Next slide, please. Now, universal testing for GDM. Pregnant women, so testing for GDM at first antenatal checkup were done with 75 gram glucose. 2 hour blood glucose levels are measured. And if it is positive, like 2 hour blood glucose is more than 140 milligram per DL, then she is diagnosed and treated as per GTM. And if it is negative, then repeat testing is done at 24 to 28 weeks of gestation. If positive, again, she is diagnosed as GTM and treated like that. And negative, then she is managed as a normal pregnancy without GTM. Now, diagnosis and management of gestation diabetes mellitus. These are the technical operative guidelines, Maternal Health Division, Ministry of India and Family Welfare of India. Next slide, please. Now, management of GTM. The guiding principles are all pregnant women who tested positive for GTM for the first time should be started on medical nutrition therapy. That is the diet and physical exercise for 2 weeks. Women should walk or exercise for 30 minutes a day. After 2 weeks on MNT, that is the medical nutrition therapy and physical exercise, 2 hour postprandial blood sugar is again tested. If GTM, GTM is managed initially with MNT and physical exercise. And if it is not controlled with MNT, metformin and the physical exercise, then metformin or insulin therapy is added to the MNT. If 2 hour PPBS less than 120 milligram per DL, repeat testing is done during second and third trimester. More follow-up tests can be done as recommended by the treating physician. And if 2 hour PPBS is more than 120 milligram per DL, medical management to be started as per guidelines. Now, what is medical nutrition therapy? The principle of medical nutrition therapy is to keep the patient healthy during the pregnancy and during the pregnancy, so that the GTM patient we can achieve a normal weight gain for the patient, as well as to decrease the over excessive growth of the baby. So MNT for GTM primarily involves a carbohydrate control balanced diet, which promotes optimal nutrition in the maternal and fetal health, adequate energy for optimal appropriate gestational weight gain, achievement and maintenance of normal glycemia. So that should consist of carbohydrate 50 to 60%, protein 20 to 25%, and fat 25%. Hypocaloric diet in obese women GTM can adversely impair the fetal growth besides ketonemia and ketonuria. So hypocaloric diet is usually avoided in GTM patient. So as per Indian ICMR guidelines, an average weight gain of 10 to 12 kg and additional 350 kilocalorie per day above the adult requirement is recommended during second and third trimester. Severe chronic caloric restriction is not recommended because of ketonemia and ketonuria in the GTM patient, which can affect the mental and physical development, both mother and fetus. Next slide, please. So what are the medical management? Metformin and insulin therapy is accepted when blood sugar levels of pregnant women are not controlled by MNT and physical exercise. So insulin can be started at any time during pregnancy. If women's blood sugar is not controlled with the maximum dose of metformin, that is 2 gram per day, 2 gram per day, MNT insulin is to be added. The dose of metformin is 500 milligram twice daily orally after a maximum dose of 2 gram per day. So the side effects of metformin are mainly GI intolerance, and serious side effect include lactic acidosis and low blood sugar. Next slide, please. Now, insulin therapy. Human ectopid and mixed insulin can be given in pregnancy in a simplified form. The dose requirement decided as first trimester 0.7 unit per kg per day, second trimester 4.8 unit per kg per day, third trimester 0.9 unit per kg per day, at term 1 unit per kg per day. If difficult in calculation, we can start with 4 units 3 times daily of obstetric insulin and then titrate twice a week, adjust the dose. And mixed insulin, 30%, it contains a 30% rapid acting insulin and 70% isofen insulin. So 2/3 of the total dose is given in the morning with breakfast and 1/3 rest of the drug is given at night with dinner. Next slide, please. The hypoglycemia. Any pregnant women on insulin can develop hypoglycemia at any time. So it is diagnosed when it is the blood glucose level is less than 70 milligram per DL. So what are the symptoms? The early symptoms include tremor of hands, sweating, palpitation, hunger, easy fatigability, headache, mood changes, irritability, low attentiveness, tingling sensation around the mouth and lip, and other abnormal feeling. Severe side effect includes confusion, abnormal behavior, visual disturbance, nervousness, or anxiety. And uncommon side effect includes seizures and loss of consciousness. Next slide, please. Now, how to treat hypoglycemia? So the pregnant woman should take 3 TSF of glucose powder dissolved in a glass of water. If glucose is not available, any substance that contains sugar that is sweet can be taken. Or if available, sugar 6 TSF in a glass of water, fruit juice, honey, etc. Can be taken by the patient. After taking oral glucose, she must take rest and avoid any physical activity. 15 minutes after, she should take some food like 1 chapati with vegetables, rice, 1 glass of milk, idli, whatever is available at home. If hypoglycemia continues, repeat same amount of glucose and wait. If pregnant is, then she develops more than 1 episode of hypoglycemia per day, she should consult immediately any doctor. Next slide, please. So special obstetric care for pregnant women with GTM, antenatal care. In cases diagnosed before 20 weeks of gestation, a fetal anomaly scan should be performed 18 to 20 weeks. For all pregnancies with GTM, and fetal growth scan should be performed at 28 to 30 weeks of gestation and repeated at 34 to 36 weeks of gestation. There should be at least 3 weeks gap between the 2 ultrasounds, and it should include fetal biometry as well as amniotic fluid estimation. Next slide, please. Now, fetal surveillance in pregnant women with GTM. Pregnant women with GTM are at increased risk of fetal death in utero, and this risk is increased in pregnant women requiring medical management. So, vigilant surveillance is required for the fetus. Fetal heart rate should be monitored by auscultation during each visit, and pregnant women should be explained about the daily fetal activity. We should ask her to lie down on her side after taking a meal, and at least she count the fetal key. It should be 1 to 3 times within 1 hour per hour after taking the meal, and total 10 times it would be better for her. Next slide, please. Labor and delivery. Timing of delivery, it depends on the severity of GTM. Usually it is done if the GTM is well controlled, then we should go for delivery 39 to 40 weeks of gestation. If a patient with GTM with well controlled blood sugar has not already delivered spontaneously, then induction labor should be done after 39 weeks of gestation. And with poor blood sugar control, hypertensive disorder, previous history of stillbirth, then patients should be advised deliver 38 to 39 weeks of gestation. Vaginal delivery should be preferred, and anesthesia should be done for obstetric indications only. In case of fetal macrosomia, consideration should be given for the elective cesarean section to avoid shoulder dystocia. Next slide, please. Okay. Special precaution during labor. So pregnant women with GTM medical management require blood sugar monitoring during labor by a glucometer. She should avoid insulin in the morning on the day of induction of labor or delivery. And during labor, we should maintain insulin dose according to her blood sugar level as shown in the table. Next slide, please. Now, post-delivery follow-up for pregnant women with GTM. Immediate postpartum care of GTM is not different from other women with GTM without GTM. So there is increased risk of developing type 2 diabetes mellitus in future. So maternal glucose level usually return to normal usually after delivery. Subsequently, 6 weeks postpartum, she should be offered 75 gram OGTT to see her glycemic status. And pregnant women with GTM and their offsprings are increased risks of developing type 2 diabetes mellitus in later life. They should be counseled for healthy lifestyle and behavior, particularly role of diet and exercise. Next slide, please. So who should be screened earlier? So according to SCOG guidelines, some risks, the pregnant women with GTM who are associated with the following risk factors should go for screening possible as early as possible. So patient overweight when BMI is more than 25, physical inactivity, there is history of impaired glucose metabolism, previous history of GTM, previous pregnancy with history of GTM, macrosomia, stillbirth, hypertension, if BP more than 140/90, HDL cholesterol less than 35 milligram per DL, fasting triglyceride more than 250 milligram per DL, and others are risk factors like associated with history of PCOS, acanthosis nigricans, non-alcoholic steatohepatitis, etc. Glycosylated hemoglobin is if there is a history of glycosylated hemoglobin more than 5.7%, impaired glucose tolerance, they should be screened earlier. And some diseases like associated with cardiovascular disease, and if there are history of family history of diabetes, they should go for early screening for GTM. Next slide, please. Diet and exercise. So nutritional assessment already told their diet should contains carbohydrate 50%, protein 25 to 30%, and fats 25%, and it includes 3 meals and 2 snacks to limit the glucose fluctuation. 30 minutes of moderate intensity exercise are recommended at least 5 days in a week or minimum 150 hours per week. Improvements seen with walking 10 to 15 minutes after each meal. So glucose monitoring should be done along with the dietary recommendation to confirm the glycemic control. Next slide, please. Now, pharmacologic treatment for SCOG according to SCOG guideline. So insulin is the first choice of therapy, and the dose depends on the depending on the body weight of the patient. So already told, so 0.7, 0.7, 0.8, 0.9 according to the trimester of the pregnancy per kg body weight. So doses should be divided, and long-acting, intermediate-acting insulin combination, short-acting insulin should be used individually based on patient glycemic pattern. Short-acting analogs are preferred over long-acting, and NPS insulin still used for the insulin glargine and determine available for the determine available for long-acting coverage. Next slide, please. Pharmacologic treatment as per SCOG guideline. If a patient cannot take insulin or declines, metformin can be used. The maximum dose of metformin in 2 grams per day. And adverse events already told, mainly GI intolerance. Maximal doses 2 to 3 grams per day into 2 or 3 divided dose depending on the body weight of the patient. And glyburate should not be used in place of insulin, and starting dose should be 2.5 to 20 milligram per day in divided doses. After 30 milligram may be necessary to obtain the glycemic control. Long-term outcome studies also still lacking. So mainly preferable drug is insulin and metformin only. Next slide, please. Now fetal monitoring. According to SCOG guideline, fetal monitoring depend on 2 categories. of the patient. So it is categorized by A1 GTM and A2 GTM. A2 GTM are those with poor control, but they are on medication and without comorbidities. They should be screened at 32 weeks gestation and earlier if there are some comorbidities are present already told. So fetal assessment for A2 GTM is generally recommended based on the understanding that there may have been poor control at some point during the pregnancy. And A1 GTM, no consensus due to lack of data demonstrating stillbirth rates. These are the patients who are well controlled on diet. So fetal assessment may not be necessary. They should be treated like normal patient, but this glucose tolerance test should be done by time to time. Next slide, please. When to deliver. So control on diet, more than 39 weeks, expected management up to 40 weeks, 6 days is appropriate. Well control on medication. So already told 39 weeks is the preferred, 39 weeks to 40 weeks is the preferred period. And poorly controlled patient, delivery between 37 to 38 weeks recommended. If there are associated other problems like in poor control of normoglycemia in hospital admission or abnormal fetal testing, then we can go for delivery between 34 to 36 weeks also. Estimated fetal weight, if it is more than 4.5 kg, counsel regarding risks and benefits of a scheduled cesarean section. Next slide, please. Now, NICE guideline update. We can skip this slide. Now, gestational diabetes criteria as per the American Diabetes Association. So screening already told it should be done in the first visit as well as between 24 to 28 weeks of gestation. And testing can be like one step, 75 using 75 oral glucose challenge test, fasting and at 1 and 2 hour or 2 hour, and two-step test include 50 gram glucose load done and blood sugar test is done at 1 hour. If blood glucose level is more than 130 to 140, then we will go for the step 2. In the step 2 procedure, 100 gram glucose oral glucose challenge glucose tolerance test is done at if at least 2 out of 4 plasma blood glucose levels are more than the standardized levels, then they are considered to be having GTM. And in the one-step procedure, GTM diagnosed, the criteria are mainly fasting blood glucose is if it is more than 92 milligram per dl, then and 1 hour glucose level is more than 180 milligram per dl, and 2 hour blood glucose level is more than 153 milligram per dl, then they are considered to be having GTM. Next slide, please. Some latest information from ESRE, European Society of Human Reproduction and Embryology. Women with hypothyroidism were more likely to suffer from gestational diabetes mellitus, hypertensive disorder of pregnancy, and gestational hypertension preeclampsia. Next slide, please. So here there was a study where a relationship with cigarette smoking with gestational diabetes was established. It was seen that GTM to assess whether an association between smoking and GTM exists or not. It was this study summary was found that women who smoke during pregnancy are at increased risk of developing GTM. Next slide, please. Now, role of metformin in PCOS women for preventing GTM. Metformin is not recommended for the prevention of GTM in women with polycystic ovary syndrome and infertility who become pregnant while taking metformin. PCOS in women with PCOS infertility who become pregnant while taking metformin, there is no strong evidence regarding the preventive effect of metformin, but metformin seems to reduce the risk of fetal loss during the first trimester. Next slide, please. Now, general consideration for diet therapy. The goals of therapy is to the aim of the therapy is to achieve proper weight gain during pregnancy by dividing her meal intake and avoiding long fasting. And it already told the calorie intake from the protein should be 25 to 30%, 50% from the carbohydrate, and 20 to 25% from fats. Next slide, please. Can glucocorticoid be prescribed to improve fetal lung maturation in GTM? Because GTM women, the fetal lung maturity is very delayed. So what are the considerations for the use of glucocorticoids? In pregnant women under insulin therapy who require glucocorticoids for fetal lung maturation, the insulin dose should be increased accordingly. And women with GTM and acceptable glycemic control without insulin therapy, warning about the risks of hyperglycemia, closer monitoring of blood glucose is advisable if glucocorticoid is advised. Next slide, please. So the screening of GTM already told. Next slide, please. So the screening for gestational diabetes mellitus in an evolving pandemic. So first of all, we should go for the oral glucose tolerance test 8 to 14 weeks of gestation. If glycosylated hemoglobin is more than 6%, glycosylated hemoglobin if more than 6.4% and blood glucose level is more than 200 milligram per dl, then she is diagnosed with over diabetes in pregnancy. And if glycosylated hemoglobin level maintains between 5.9 to 6.4% and blood glucose level more than between the range of 160 to 200 milligram, then she is diagnosed with early GTM. And if it is the glycosylated hemoglobin is less than 4.9%, she more less than 5.9%, she is having she is diagnosed with free from the GTM. Those patients are again tested at 24 to 28 weeks of gestation, and again we found that the glycosylated hemoglobin more than 5.7%, fasting blood sugar more than 100 milligram per dl, random blood sugar more than 162 milligram per dl, then she is diagnosed with GTM and treated accordingly. Next slide, please. Management of GTM in COVID era. Here we can see that the para health worker, they have a contributable role in this treating GTM in COVID era. Next slide, please. Role of myoinositol in GTM treatment. There was a study done by Curious. Here we can see that a cumbersome administration method and a high chance of side effects such as hypoglycemia weight gain have made insulin a problematic and debatable option in the prevention of GTM. So nutrition supplement inositol has been shown to be a safe and easy to administer alternative. Based on current evidence, myoinositol supplementation reduces the risks of GTM among obese and overweight pregnant women, as well as women with PCOS or a family history of type 2 diabetes mellitus. Next slide, please. Here again, clinical evidence of use of myoinositol in GTM. Study was done, a publication was done. Role of myoinositol in GTM treatment. It is believed that myoinositol, due to its insulin mimetic qualities, activates the glucose transport for translocation to the plasma, thereby increasing the glucose uptake by the cells and thereby decreasing the insulin resistance during pregnancy. Next slide, please. Next slide, please. Now, take home message. Gestational diabetes mellitus can be easily controlled by diet and exercise. Only in few women in whom blood sugar is not controlled by diet and physical exercise, oral anti-diabetic or insulin injections are required. GTM can be treated with oral metformin tablets as well as they do not harm the fetus. Insulin injections are required only during pregnancy according to their body weight. Insulin will be stopped in most of the cases after pregnancy. Injecting insulin over abdomen is 100% safe. Modification of diet is very easy, so it should be avoided at all times during pregnancy. If blood glucose is controlled, patient and her baby both are safe and healthy. Pregnant women with GDM should deliver at health facilities. It will help in management of any complication which can be countered during delivery. With this, I'm finishing my talk. Thank you very much. Thank you.
Yeah, thank you, ma'am. Thank you, ma'am, for the wonderful presentation. We are very honored to have you, ma'am. It's very learning to hear you, ma'am. Ma'am, if you allow me, then we'll take the questions. Hello. Hello.
Hello. Hello, ma'am.
Hello. Yeah.
Ma'am, if you allow me, then we'll take the questions. Hello. Hello. Hello.
Hello.
Yes, ma'am. Ma'am, if you allow me, we'll take the questions. If any questions from the delegates.
Okay.
Yeah. Ma'am, we have first question, that is it necessary to treat postpartum after diagnosing with GDM?
So postpartum?
Is it important to treat postpartum during after GDM? I think they're talking about postpartum GDM.
Actually, it depends on the patient, because some patients with GTM, they may not develop diabetes immediately. So there is an increased risk of developing GTM in near future or later in life. So we should go for this glycemic status of the patient at 6 weeks of gestation, 6 weeks postpartum. If it is normal, then no need to treat her. And if she's diagnosed again with a type 2 this hyperglycemia, then she should be considered as the having type 2 diabetes mellitus. So she should be treated accordingly.
Thank you, ma'am. There are no more questions from the delegates, ma'am. If you allow me, then we'll close this webinar.
Thank you so much.
Thank you very much, ma'am. And we are very honored and glad to have you, ma'am. We look forward for your continued support for this educational initiative. Thank you very much, and many thanks from the Shield team.
Okay, thank you so much.
Thank you, ma'am.
Thank you, madam.